This week, the ASC Podcast with John Goehle returns with an information-packed episode. We discuss current news, including the nurse who was arrested for administering the incorrect medication, preparing for USP 800, mentoring of new nursing leaders, how to deal with lapse in a quality assurance and performance improvement program, how to prioritize projects in preparing for a survey, assuring you comply with your state's reporting requirements, and a focus segment on budgeting.
Welcome to the ASC Podcast with John Goehle, a bi-weekly podcast for anyone interested in the freestanding ambulatory surgery industry. This episode is sponsored by Ambulatory Healthcare Strategies. The ASC regulatory environment is increasingly challenging, but organizations that outsource their regulatory oversight to ambulatory healthcare strategies have an edge. AHS works with ASCs to oversee their quality improvement, risk management, emergency and infection control programs, run their meetings, develop education programs, and always be prepared for surveys. Welcome to episode 48 of the ASC Podcast with John Goehle for Monday, March 4th, 2019. We're recording from our studio in Rochester, New York. This is Sue Cronkite, Senior Nurse Consultant with AHS. I'm here with John Goehle. John is one of the leading experts in all aspects of the freestanding ambulatory surgery industry, and he's the author and co-author of over 10 books about the ASC industry, including the Survey Guide for ASCs and the recently released Finance and Accounting for ASCs. John speaks frequently at both national and state ASC meetings on a wide variety of topics and is the owner of Ambulatory Healthcare Strategies. So it's been kind of a long break for us.
It has, man. Well, quite a number of reasons. First of all,
yes.
I believe we recorded our last episode from our vacation in Hilton Head. That was last month, wasn't it?
Yes, it was.
Yes, and then unfortunately, during that vacation, both you and I got sick. And we were still recovering. Our voices are still not back to normal, as you can hear. I've been on antibiotics. I haven't been able to talk, which you've enjoyed.
It's been torture for you.
So I was just telling you before we started recording, this is great to be in front of the microphone again because I like to talk a lot. So, but it's also been a very busy 4 weeks, I think, since our last episode here. And the organization, Ambulatory Healthcare Strategies, which we work for, has had a very busy time of it. We opened a new office-based surgery practice in Staten Island just after we came back from our vacation. Had another great survey with almost no problems, and we look forward to working with this unique, it's actually going to be an OB/GYN office-based surgery practice in Staten Island, so we're very proud of them. And we're back to recording, of course. We're hoping to get back on schedule here. We probably will have to make up some time because, man, when I was putting together the script for this episode, we had an awful lot of things to talk about. So so this will be a bit of a long episode. We apologize about that, and we'll make sure that it doesn't get too long, and we'll put some more material in a short couple of weeks or maybe even a week.
Okay.
So Sue, why don't you give us an update on news from the industry?
For our New York State listeners, a new patient bill of rights has been issued, so just be aware of that. That's something that you'll want to post an updated version of.
Yeah, as a matter of fact, a number of our clients, when we notified them, said that they had just actually gotten a nicely printed and framed copy, and they had just received it like days before the new patient bill of rights came out. So it just shows the importance of staying on top of these things. And I know this is only for New York State, but it does show the importance of keeping on top of things that are going on in your state and making sure that you're constantly scanning that information, or rely upon organizations such as Ambulatory Healthcare Strategies, if you're lucky enough to hire us, to help you keep on top of that.
Yep. So I just wanted to discuss a little bit about the nurse that worked at Vanderbilt that had the medication error and is being criminally prosecuted for that error. I'm not sure if everybody's aware of it, we're not going to go into big details, but basically she gave a patient the wrong medication, vecuronium, rather than Versed. And the unusual thing about this case is that she's being criminally prosecuted for that error.
And this is very scary, Sue.
Yeah.
I think you as a nurse in particular, because criminally prosecuted. And by the way, I think you indicated that she's not actually getting any disciplinary action against her license.
No, the state has ruled that they're not going to put any disciplinary action against her. They feel that it was a mistake.
Yeah, this is very scary, and I think we can agree that if there's a pattern, then we have to start thinking about this. The Dr. Death episodes, famous podcast that's going on right now. If you haven't heard it, Dr. Death talks about a doctor that injured and killed quite a number of patients, or allegedly did, and as a result of that is in jail.
And that seemed to be very, as you said, it was a pattern.
Right.
He didn't do anything to change it. He didn't try to improve anything. Right. So, I think in that case, it's different.
And even that is controversial. Matter of fact, that case is still going on. And it's very controversial because of the criminal aspect of it. Yeah. But here we have a nurse that only had one, to our knowledge, only one incident. So.
Yeah, and I guess a key point in the case is that she did an override on the medication dispensing cabinet. But the problem with that is that that's a very common practice. Yeah. So you can't say, well, this is what you're supposed to do in your everyday work life, but if it causes a problem, well, then you're held responsible. So if that's going to be the key in the case, then maybe they should change the rules that you have to have a second person with you if you're going to do that. The other thing is the autofill feature. So what had happened is she was typing in Versed, she typed in the VE and vecuronium popped up, and she, like the autofill on her computers. And, she clicked on that. Now, obviously, she made a lot of mistakes along the way, but those are a couple of things that could be changed, that could be backed up a little bit. So maybe this wouldn't happen in the future. As you said, the big concern with this is if we start to criminalize this and punish people will just be more afraid to come forward. We want to have open discussions and confidential peer reviews to figure out how to build in more safeguards.
And it really runs contrary to the quality assurance and performance improvement program requirements that we have in place.
Yeah, it really sets us back on what we keep talking about as the good catch of really encouraging people to talk about the problems that they see.
Right. And so I guess there was an American Nurses Association statement about this situation.
They put out a statement on February 19th saying, healthcare is highly complex and ever-changing, resulting in a high-risk and error-prone system. However, the criminalization of medical errors could have a chilling effect on reporting and process improvement. The Code of Ethics for Nurses states that while ensuring that nurses are held accountable for individual practice, errors should be corrected or remediated, and disciplinary action taken only if it is warranted. When errors occur, whether it is one's own or that of a coworker, nurses must neither participate in nor condone through silence any attempts to conceal that error. Again, we just, we need to encourage people to come forward with things. So it'll be interesting to see what happens with this.
And we'll keep a very close eye on this case. So our friend George Skoras gave us some information about the upcoming USP 800. USP stands for the United States Pharmacopoeia. And this is document number 800, which becomes effective in December of 2019 after quite a number of holds. So, Sue, you've done some research on this and found some interesting information.
Yeah, well, the biggest impact is on hazardous drugs. The document requires that organizations prepare a facility-specific list of hazardous drugs accessible to all staff and update it when new hazardous drugs are incorporated into the center, as well as during annual reviews. It requires specific training on handling those drugs, like policies, personal protective equipment, managing exposures, and how to dispose of that medication.
So, I don't think about ambulatory surgery centers as handling a lot of these types of drugs. So what do we use in an ambulatory surgery center that would be applicable here?
Well, the biggest one is the topical mitomycin that's used in ophthalmic centers.
Oh, right. In eye drops, right?
Yes.
During and after surgery. Yeah.
Yep. And under these new guidelines, hazardous drugs must be stored, unpacked, and prepared separately from non-hazardous drugs. And for mitomycin specifically, if you are not using a single dose, you will most likely be required in the future to do that, or to use a compounding pharmacy to unpack into the multiple doses.
So that's a pretty big expense, of course, and I think that's our big takeaway here is to get prepared for this. There's still a lot of information coming out about USP 800. As you and I were researching this, we had a lot of conflicting information, so we came up with the consensus information, but we will keep a very close eye on this one also. So I thought let's discuss, as we always do in our episodes, things that are going on in the past few weeks in our own experiences. And one of the big things is we spend a lot of time mentoring our administrator nurses. One of the issues that we have, and we've talked about in the past on this show, is that nursing administrators are very difficult to find now, and often we're having to recruit individuals, nurses that have a great experience, but not necessarily in nursing administration or in management.
Or not at an ASC.
That's true, right. A lot of them come from the hospital environment. And as we talked about in the last episode, this mentoring is becoming a big part of what we do, and I'm sure it's a big part of what many organizations are having to deal with. So I can't overemphasize the importance of good mentoring. It takes us a lot of time, when we're working with our centers here to make sure we not only keep the place going and their quality improvement, risk management programs, their preparedness for surveys, policy manuals, et cetera, all of those things up to date, but mentoring the nurse managers so that they can not only deal with the regulatory issues, but also deal with managing the staff and managing the schedules is a very difficult task. I think the important thing I just wanted to mention here is we're coming up in ASCA 2019. It's a fantastic conference coming up in Nashville in May, and this is a great opportunity for those nurses that are still learning, as well as people that are experienced, of course, but especially for those nurses that are still learning about the industry, to get out and talk to other people, to listen to some incredible speeches and presentations about what it is to be a nurse manager, what it is to run a ambulatory surgery center, and what the requirements are from a regulatory standpoint. So please, if you're an owner listening to this, open up the wallet there and pull out some money for the nurse to attend this conference. It is well worth it. And I have this story, and I think this is very true. I'm not a nurse, obviously, but as an administrator growing up in the 90s in the industry, I walked into a situation where, there were very few ambulatory surgery centers in New York. As a matter of fact, there were only 20 of them, and we were all starting up about the same time, and we didn't really know what we were doing. And so I actually formed the New York State Association of Ambulatory Surgery Centers out of purely personal reasons there, because I wanted to meet with other people and talk to them and see what their experiences were. And that's how the New York State Association of ASC started. And I can't overemphasize what I learned by going to those conferences and obviously going to the national conferences. This is an important opportunity. You can't, in our industry, learn by doing. You really have to get some, learn. I mean, obviously that's one important way of learning, but it can't be the only way to learn. And you don't have to reinvent the wheel. So meeting people, attending conferences like this, and meeting other people that are going through the same thing are very helpful to people's career. So please do consider attending ASCA 2019 and supporting the ASC Association, this wonderful industry representative of ours.
Totally aside from all of the sessions that you can attend that you would learn a lot at, it's really just that networking and meeting other people, and maybe you'll have ongoing connections where you can have somebody you can reach out to and just hear everybody's experiences. As you said, it's invaluable.
Right. Well, and we told the story after ASCA 2018. I had done a presentation on I don't even remember what the presentation was on, but you and I were there afterwards for an hour and a half with people that had attended the session, talking about what I had spoken about, and just talking about things that were going on in each of those centers. It was one of the most enjoyable parts of that conference, even though it put us way behind schedule in many other aspects. But those things are incredible, and it gives you a good opportunity to meet up with people. And by the way, we are going to be there. I think we've all signed up, so you and I will be there. Alex Borneman, our Director of Operations, will be there. Lori Rodricks will be there, who is our Director of Clinical Services and also our resident expert in infection prevention, and Judy D'Ambrosio, who's the Director of Educational Services. So please stop us if you see us. Send us a text, send us an email. We'll be glad to meet with you while we're down there. So we have been dealing with a lot of new centers that have come on board with us lately who have hired us basically because they've had some issues with their quality assurance programs. So we've been learning a lot, or we've been having to deal with a lot of issues where basically many times these quality assurance programs have kind of gone on hold or have not been kept up. Often this happens because a nurse leader has left and nobody knew how to follow up on it, or they just thought, well, we'll deal with it as we get to it, or they just get very lax after a survey's done and don't follow up on things, or people change and they don't even know that there are requirements for this. There are a variety of reasons that this can happen. So an interesting issue has kind of developed with some of these centers that we've been taking on, and that is, what do you do with that time frame when the quality assurance program has not been, working fully up to par?
Yeah.
And so I just thought we would talk about that very briefly here. And what our advice is largely to kind of acknowledge, even in your quality assurance program and in your governing body, that there was a lapse and that you are rebuilding that program. There's a requirement that you have to do an annual review of the quality assurance program. And often we just write down, well, the quality assurance program was very effective this year. We had the following successes, blah, blah, blah. And therefore we're going to continue with the same program. But obviously, if you don't have an effective program, admit it. Write down what your plans are going to be in the future and immediately implement processes to get yourself up and running, and admit to the past problems so that when the surveyors come in, and it could happen very quickly, of course, you can demonstrate that you found the problem, you fixed the problem, you're moving forward very quickly, and don't try to, create something. Right. Don't try to hide it.
Yeah. Just show very clearly all the work that you're putting into it moving forward, so that they know you're taking this seriously and this is a discovered problem that you are fixing.
Right. And I think it's also important to remember, do it right, not fast. Now, it's important to get your program up and running so that you can demonstrate quality and that you provide good quality care, but it is extremely important that you do it right. So get things organized and moving, as quickly as you can, but make sure that you're doing it right. Surveyors want to see an ongoing process. They want to see improvement. They want to see continuing improvement in the program. And they also want to see that the doctors are involved in this. That's a big problem often, is that the physicians are not directly involved in it. Get them involved and make sure they understand, how serious this is to getting going. And what I would recommend is, if you did have a program that kind of fell off the radar for a while, that you pull up all the information that was gathered during that time, because a lot of information probably was on autopilot and was being gathered, and then, hold a meeting to kind of go over all the stuff that was going on during that period that it was not running, have a specific meeting that goes over that information, and then talk about how you're going to fix things into the future. So that's our advice on how to deal with lapses in your quality assurance programs. Another thing that happened recently is, one of the new centers that we took on, the administrator was very focused on her policy manual, almost too focused on her policy manual. And, she quite frankly seemed to she wanted to kind of do one thing at a time. At least when she was working with us. And this focus on the policy manual, unfortunately, probably was misplaced, because what we really want to do is make sure that we have, all those things that are extremely important to the ambulatory surgery center's ongoing operations. So, while the policy manual is important, doing the right stuff is much more important. Making sure your staff knows what they're doing. And sometimes they don't learn that from a policy manual. That's, by mentoring those individuals, by doing good training and getting that part fixed. And that allows you to then go back to the policy manual to make sure that you're matching the policies or things that are going on in the organization with what is actually happening, and you're doing the right thing. So getting that quality improvement program operating properly before perfecting the policy manual is extremely important. And that leads us to another issue, and that is educational programs. So, this is one of those areas that we have been, as a company of Ambulatory Healthcare Strategies, has been doing a lot more of, is developing educational programs. And matter of fact, that really has become a major part of what we do with our organizations. So it's important that you're on top of developing a good orientation and mandatory education program. We did talk about the importance of not relying on online programs entirely for this. As a matter of fact, the online component probably makes up less than a third of the educational programs that you should be doing at orientation and mandatory education programming on an annual basis. So make sure that you're doing these annual education on a regular basis, and that they are obviously provided at orientation education within 30 days of hire. And also important that you're educating not only your employees, but also your credential providers. The physicians have to have you have to document that they have been provided education in various aspects of your organization, including your infection control program, peer review, how to transfer a patient, etc. And by the way, another issue that's been come up recently is that we need to demonstrate that our vendors have gone through some type of a truncated program of education so that they're aware of the emergency procedures in your operating rooms, as well as the importance of maintaining a sterile field if they're actually in the operating room. So you should be developing some type of a program to demonstrate that those vendors have been given that education. Okay, I think that's it for this segment. Why don't we take a short break and we'll come back and talk about budgeting.
So one of our listeners asked if we could talk about budgeting a little bit. And I know you're going to do a couple of sessions at ASC 2019. So you're going to give a quick rundown.
Yep. I'm going to give a kind of a brief overview of budgeting in the surgery center. If you want more details and are going to ASC 2019, which we highly recommend you do, I'm going to be doing 2 sessions. One is the CASC review class, which will be on the Wednesday of the conference, and that is a special class. It's a additional cost. Okay. And then during the regular conference, I'll be doing Finance 201, where one of the segments we'll be talking about there is in budgeting. So this is a brief overview. I'll try to go relatively quickly through it, just to kind of give you an overview of budgeting. Now, one of the things that I do when I'm speaking in public about this is ask how many people do budgets. And usually we get about half of the audience who talks about it. And, I'm quick to point out that it isn't necessary in every organization, but larger organizations tend to require them or need them. And especially organizations that are affiliated with larger places such as hospitals or management companies will have a budget. So a budget by definition is a plan that forecasts revenue expenses for an organization. And so the big question, of course, is why do we budget? What's the purpose of it? It should be part of a strategic plan or a business plan of the organization. So the best budgets are those that are tied into your long-range financial plan that you've developed as part of your strategic plan. Now, the name of my organization is Ambulatory Healthcare Strategies. My master's was in strategic planning. And so strategic planning is something that we take very seriously here. But strategic planning in an ambulatory surgery center doesn't have to be as complex as a 30-page written document that took 7 years to develop and 4 years to implement, and included retreats and things like that. It can be something that can be put together relatively quickly in an organization. The most important thing about a strategic plan is it helps you to kind of figure out what your direction is going to be for more than 1 year. You want to be able to set some goals for the organization so that the administrator knows what they're supposed to be doing and the governing body agrees with that direction. So why would you budget? Well, it's a good way of benchmarking. It's a good way of comparing the results of your financial operations to something that you've put together, such as a budget here. So if you want to set goals as a governing body, a budget is a good way of doing that. Financial goals, that is.
I like how you put it in such a positive light that it's a way of meeting your goals. I always thought of a budget as kind of restrictive and something I'm locked into, but really, the way you present it is that it's really helping you get where you want to go.
Right. And actually, that's a very good point, Sue, because I think one of the problems with this is it always seems to, I think one of the reasons that people have asked us to talk about budgeting is because they tend to be draconian. They tend to be pushed on administrators. And sometimes I've heard about administrators that have been given a budget. There's this great story, one of our clients, as a matter of fact, that the nurse administrator was told that she had to cut $300,000 out of her nursing budget by the owner of the company. And clearly the owner of the company didn't know his finances because the entire nursing budget was $500,000. So she would have had to gotten rid of 60% of her staff. Yeah. And,
not a good plan.
Not a good plan. And, so that had to be corrected pretty quickly. But the takeaway there was that, and we'll mention this when we finish up with budgeting, is that this is something that should not be a way of shackling an organization. And, I think one good thing about budgeting is it helps you to identify problems before they become major. So when you're comparing numbers against some type of a benchmark, such as a budget, you can start to see how things might be getting out of kilter right away. Or, by the way, use that positive positive tone, maybe something's very successful. Maybe you were very surprised because one area of your operation is suddenly doing much better than another. And it's important for you to give the resources there. Again, another story, back in my administrator days before I became a full-time consultant, we had an operation where one of the doctors' volume had been increasing by 20-30% a year, but none of the other doctors who were in the same specialty really wanted to ever acknowledge that he was doing so well. And so when we demonstrated as part of our budgeting that his growth was coming much faster than we had budgeted for it, we needed to give him more resources. And by using this budget, we were able to demonstrate the reason that he needed more time was because of this. And obviously, controlling costs is probably the reason most people put together budgets, but it should not be the primary reason. But it's one way to set goals with regard to how much you're going to spend on various categories. You want to provide people with educational opportunities, but you don't want to give them a budget that's so broad that they're attending every single conference.
Yeah, some type of guideline.
Right. Budgeting is also extremely important in planning for major equipment purchases. So in this area, I always point out, you never want to go to your owners and say, this year we need to spend $500,000 on new equipment. And by the way, there are not going to be any distributions this year at all, because that's what we call a career limiting move. So you want to make sure that you've planned these purchases out over a very long period of time and, work with the owners to show, when these purchases are going to come through. Determining profitable and unprofitable services. Another reason you might be doing budgeting is if you're budgeting by cost center or, specialty, this will help you to look at your different specialties and say, okay, maybe I'm not doing so well in plastic surgery, so maybe this is something that I'm going to have to phase out because I'm making more money in this other area and I'm running a very limited amount of time in my operation. And adapting to and anticipating changes in the operation or the industry. So this could be, and budgeting in these years are particularly important. When 2008, before the 2008 changes in the revenue system for Medicare came out, I was on a very robust speaking tour where we were going around the country talking about the impact of the new Medicare reimbursement program on ambulatory surgery centers and what the 4-year phase-in was going to be like. And we helped them a lot in developing budgets and projections to be able to determine what the impact was going to be and try to figure out how they were going to have to adjust other things if the revenue was going down. So there are different types of budgets. The ones that when we say budget, most people think about what we would call the operating budget. In other words, a budget of revenues and expenses. But there's also capital budgets. And my best advice on capital budgets is to make it very simple. Just create a spreadsheet with 5 columns going across for the current year and the next 4 years, and lines going down with all of your major equipment purchases, and try to predict where those major purchases are going to come. What year you're going to need them. When is your sterilizer finally going to give out? When are you going to have to replace your endoscopy machines? When is that phaco emulsifier, going to age out or become functionally no longer valid or useful in your industry?
So I'm wondering, do you do all of these different budgets and then you use those to tie into your overall budget, or do you?
Good question. No, these are different types of budgets that you might have in your operation. For example, let me mention all the budgets and then we'll go back to that very question, Sue. So there's also the cash flow budget, which is where you budget the revenues and expenses and what flow they're going to have. And then there's break-even analysis and sensitivity analysis, which are very specialized types of analysis. So getting back to your question, most organizations probably only need an operating budget and a capital budget. If that. And I will say every organization should have a capital budget. That's an absolute. We're going to talk later how operating budgets in some small operations are probably not very valid. So we'll talk about it a little later. Cash flow budgets are important when cash flow is a problem. And that's not always the case. If you got a well-running operation that's been doing very well financially, cash flow might not be your biggest issue. But cash flow is often a big issue in the beginning years of an operation. So, just as you're starting or getting into operations, a cash flow budget is going to be extremely important. Break-even analysis and sensitivity analysis are things that you prepare when you're trying to bring on new services or adapt to changes going on. We're not going to really get into those here. We'll probably have some future podcasts where we mention them. So who is involved in the budget process? Well, unfortunately, very frequently, it's done by one person. It's what we call the dictatorial approach, where somebody sits down, puts together the budget, tells everybody this is the number. That's really not the right way to do it. The best way to do a budget is to talk to your governing body and get some guidelines. What do they expect in the future? What are their goals for revenue growth? What do they want to see with new services or things going on? And then talking to your staff, what are the things that they need? Maybe they need some new equipment that you don't know about. Maybe they're really understaffed in a particular area. Maybe they're overstaffed in another area. I don't think people would usually admit to that, but who knows? And so bringing your purchasing department in, because they're going to know what types of cost pressures are out there. Talk to your nurse manager about your staffing needs in the future. Maybe you're bringing on some new services, or some doctors are growing at a much more rapid pace than others, and that's going to require more nursing time. So talk to them about that. So in the industry, or in accounting, we have two types of budgeting systems or ways of doing a budget. One is what we call the incremental, which is the most common, and the other one is called zero-based. Zero-based is something that came out in the 70s and 80s, and it was meant to be a way of kind of avoiding that. This last year we spent $100,000. This year we're going to spend $103,000 as a result of inflation, and stopping at that. The whole idea behind zero-based budgeting is that every year you have to go back and justify every single expense in your organization right from scratch. Incremental approaches are much more common. Zero-based approaches, in particular, were things that were targeted at nonprofit and governmental agencies. I can remember when I was an accountant working in the public accounting field, I was often called upon to assist in doing financial projections for governmental agencies, and sometimes we'd be called in to project for the local government what the impact was going to be, say, on a nursing home of the rest of the year. So we have to project from July through December based upon January to June. And one thing we would know is that no matter what, they would never be under budget in any area. By the end of the year, they will have spent everything, because they always had this attitude: if we don't use the budget, we're not going to get it the next year. And that's what really generated the whole discussion about zero-based budgeting. So how do we start? Where do we begin when we're doing a budget? So revenue is often one of the more complicated areas in budgeting in an ambulatory surgery center. And I like to make it relatively simple. So what I try to do is I get, detailed procedural reports by physician, by carrier, and payer, which doesn't sound simple, but based upon the types of information you might be able to get off of your system, you should be able to get this information and use prior reports and prior revenue cycle information to be able to project into the future. And then focus on what's going to be the changes next year. So look at your physicians. What do you expect in terms of growth based upon their past performance and discussions with those doctors? So talk to the doctors, talk to the offices, find out what's going on. Do you have doctors that are about to retire? Do you have new doctors coming on that are coming into the practice? Get that information and put that into your budgeting matrix as you're putting it all together. And, get detailed information about how much revenue you're generating currently by procedure, and if possible by carrier, so that you know how to project things into the future. Focus also on payers that are going to be changing the reimbursement. So, every couple of years or every year, sometimes you might have a contract renewal with one of your contracted payers. Find out what that is going to be. It's important also, if you do a lot of Medicare, to look at the new Medicare reimbursement information that comes out in November of each year, and the preliminary information that comes out in July. Because as we know, even though the total increase in the reimbursement to the industry remains at a relatively low level based upon some type of price index, the industry changes can be quite dramatic. We saw that this year, for example, pain management went up a bit, but there was a huge drop for vascular access procedures, and well above and well below in those cases what the average increase was for, across the whole Medicare system. Yeah. And then put this all together in a nice little spreadsheet. And by the way, you don't have to do this by yourself. Often you can call upon your accountants or consultants, obviously, to help you with this process. So if you're not completely comfortable with it, ask them to assist you and maybe provide a spreadsheet or put together a spreadsheet for you to work off of. And then moving on to expense budgeting, I do recommend, I found that zero-based budgeting is way too complex for ambulatory surgery centers. So I really do recommend, going into it by looking at what your prior year's numbers were, and then, delve into them deeply. I mean, I'm not saying go totally zero-based, obviously, but look at those numbers and try to figure out what's going on. I speak an awful lot about using statistics for budgeting for your nursing or for your clinical staff. So instead of just looking at your staffing there, try to turn that into average clinical hours per case, which we've talked about in this podcast a number of times. I speak about it a lot at my conferences. But using average clinical hours per case as a proxy and multiplying that number by the number of cases you're projecting and multiplying that by the average nursing and other clinical staff reimbursement is a good way of budgeting. And it helps you also to figure out trends in organizations such as those in the north that tend to have, fluctuations, in many places like in our hometown here in Rochester. A lot of our older people tend to go south for the wintertime, so they're not here for their colonoscopies and their eye surgeries during the month of February, but then they come back and we're very busy during the summertime. So this that type of a budgeting helps you with that. It also provides some good benchmarking, means by benchmarking using the clinical hours per case to figure out what happens when you're not quite meeting those targets that you've set. So finishing up on expense budgeting, watch the trends, make sure that you're keeping on top of things. There's been a lot of discussion lately about dramatic increases in the expenses for biohazardous waste. And, one of the organizations out there has been well known for increasing their numbers quite dramatically, and that's driven a lot of competition into the industry. So that has been helpful in getting people to compete with those big players. So, when you see your expenses going up dramatically in some of those areas, start to ask questions. Even if you're not totally serious about changing vendors, the fact that you tell your current vendor that you're looking somewhere else usually gets them to loosen up a little bit, and they want to keep the business. As we all know, it's more important to keep current clients than to develop new ones. So I want to kind of finish by talking about budgeting in the small center. So everybody, I think, kind of runs into this assuming you really should have a budget in your ambulatory surgery center. And the truth of the matter is many small ambulatory surgery centers find that if they put together a budget, it is almost useless by month 3. And then you spend most of the rest of the year when you're doing variance analysis with these budgets, trying to explain away things that happened in the first couple months. Ambulatory surgery centers that are small, that are subject to dramatic changes as a result of a doctor going on vacation for a month, for example, or having some sudden changes, or, maybe a doctor comes and does a bunch of cases and then goes away. Those things have a dramatic impact in a center and actually make these budgets almost useless. So over the years, I've moved away from my accounting profession attitude toward budgeting and said, wait a minute, in small centers, maybe a rigid budget or maybe a formal budget isn't quite what we need. And I encourage organizations there not to give up on it completely, but to consider doing what I would call a rolling budget, where you look at the past 12 months, you put them on a spreadsheet right next to each other, and you kind of roll those numbers forward for 12 months. And that gives you some ideas of what you expect your expenses to be, and then compare yourself each month to that goal that you had set the previous month, and use those numbers that are moving forward to give your owner some idea of what you expect your expenses to be moving into the future. So in that way, you're not doing necessarily variance analysis like you would in a traditional budget, but it gives you an opportunity to look at those numbers and say, hey, wait a minute, I'm seeing this trend. And really, that's the important thing here, is doing trend analysis, looking at the tracking, like we do in quality improvement, looking at the tracking and trending of these individual line items. So, I encourage organizations to kind of think a little bit differently. Small organizations think differently about budgeting. And by the way, even large organizations now might find that this is, the best thing for them. I worked with a very large organization a number of years ago. We ended up actually, I guess we could say, firing that particular organization because they were doing some things that were quite unusual. And what it came down to is that the organization used the budget as their financial statements. So if they didn't meet the budget for the year or for a given month, they would accrue revenue or accrue expenses in order to meet the numbers that were in the budget. So basically every month they went back to the governing body and reported the numbers that were on the budget, or very minor differences, which meant that at the end of the year, especially when it was not going quite the way they expected it, they had to explain away an awful lot of differences. I did not want to be there at the end of the year when they had to explain away all of those differences that we knew were going on during the year. So that's a real downside in budgeting, is when they are misused. And this organization happened to be affiliated with a hospital. hospital. And that just kind of, shows how these things can be misused if they're not done properly. So that's kind of my take on budgeting. What do you think about budgeting in general now? Are you an expert on it?
No, but I understand a little bit more about it. And as I said, I think I understand more the purpose of it as opposed to, just giving you something you have to stick within. It's a good way of kind of seeing where those trends, when you relate it to the quality improvement, it really, it makes a lot of sense. That use it as a really good tool to get where you want to be.
Right. And I think this is important for nurses to understand, since so many nurses are really involved in this. They might not be necessarily involved in putting together the budget, but they're kind of forced to use these budgets, is make sure that they, if a budget has been thrust upon you as a nurse, you really need to insist that you know the details of it. Maybe you can't control what goes into the budget, but at least tell the person that's put together that budget, I want to know what the numbers mean. Where do they come from?
Yeah, and have some input if you can.
Right.
I mean, it seems like every department really should have some input.
Right.
And letting people know what they need and where they can cut back.
Right.
So they're not forced to make decisions that aren't good for the patient or for the operation.
Right. And I've told this story probably on the podcast. I certainly use it in my speeches, that, once I was interrupted in a speech by an audience member who said, I'd been talking about the importance of the nurse manager understanding what's going on in finances if they run the place and are responsible for the budget. And she said to me, well, what happens if you're not given access to information about finances in your operation? And I said to her, are you responsible for the financial operations and the budget? Oh, yeah, I'm responsible to make sure that I keep my costs down. And I said, so what do you think you should do? And she kind of stammered. And I said, quite frankly, if you're not given access to that information, this is not a job you should be doing. You really should quit. It was kind of a rough answer to that. And, people giggled a little bit in the audience when I mentioned it, but it was serious, because if you're not given the proper information to do your job, if you're, not given the resources that you as a nurse need in order to carry out a responsibility that you've been given, then you're
it's a bit of a setup.
Yeah, exactly. That's exactly right. You've been set up to fail. So. So I just wanted to end the segment by just giving some general conclusions about budgeting and the ambulatory surgery center. So budgeting can definitely make you more efficient, and it can help you, meet those goals or set some goals, and then give you some guidance or give you something to compare yourself against. Provides a mechanism for making choices between different options. If you're trying to figure out, which services you're going to be offering and making a choice between the more profitable ones, then this is a way of doing that. It also holds employees accountable, for expenses that they're incurring. And let me just finish by some budgets, do's and don'ts. Don't let the process eclipse the goal. In other words, don't get so involved in putting it together that you completely miss the goal of the budgeting. And as we said earlier, make it a tool, not a shackle.
Sounds good.
So let's take a short break and we'll be back and we'll talk about upcoming events.
Okay. John, you've written a number of popular books about the ASC industry. Can you tell us about them?
Sure. So the two that are in publication right now, which are most popular, is the ASC Survey Guide, which is a guide to the ambulatory surgery center conditions for coverage and interpretive guidelines. And it basically, it's very, very long, but it's a nicely indexed book that provides all the regulations applicable for Medicare certified surgery centers in the United States, with the interpretive guidelines nicely referenced so that you can find the interpretive guidelines that apply to the specific regulations, as well as any of the additional information that's provided by CMS for each of those regulations. And the second book is the ASC governance book, which is a great book for either governing body members or owners of surgery centers, or the administrators who like to know what the surgery center owners need to be doing. It's nice and short because it's written largely for doctors who have short attention spans. Just kidding. But anyway, it's a good book to understand what responsibility you take on when you join the governing body of an organization. So,
okay. And how does someone get these books?
So please visit reg-books.com. That's regbooks.com, regbooks.com. And you can purchase both of those books at that website. You can also get a special offer if you purchase a book through the website for a one-day consultation with me for $19.95, which includes a tour of your facility, review of your quality assurance program, governing body meetings, look at the sample of medical records, credential charts and employee charts, scan of the policy manual, kind of review, quick overview of the life safety stuff. And it includes a very comprehensive debriefing afterwards, a full day on site with you. I love doing these things. It's great to get out and talk to people. Most of the time, people are really grateful. Actually, all the time, people are very grateful for this service. And at $19.95, you can't get a better deal. You can also buy the books on Amazon or most online book websites.
So let's talk about some upcoming events in the ASC industry. Every episode, we inform you of upcoming events. If you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com.
The next Certified Ambulatory Infection Preventionist exam, or QAPI exam, is this month, March 1st to the 31st at testing sites throughout the United States. Hopefully everybody put their electronic application in between January 1st and 31st. And for more information about upcoming exams as well as the sites for this exam, please visit aboutcaip.org. That's aboutcaip.org.
Registration opens for ASCA's 2019 National Advocacy Day on September 24th in Washington, D.C. The registration opens on March 4th. You can just go to the ASCA website and sign for that.
The next ASC Association webinar, Engaging Your Supply Chain Resources to Gain Understanding and Provide Leadership, is on Tuesday, March 12th, 2019 at 1 o'clock p.m. The speaker is Todd Ike, who is Director of Training and Implementation for USP, and participants will get 1 hour of AEU or CE credits. And the webinar examines supply chain functions in your ASC from an administrator's point of view. Learn how to identify the professional materials manager, understand procurement transactions, and conduct meaningful data analytics in your center. Get tools to help you manage cost and drive efficiencies. Both new and experienced ASC administrators will gain valuable insights on how to engage with their materials manager in order to better implement an efficient, cost-effective supply chain for their organization.
The Texas Ambulatory Surgery Center Society 2019's annual conference is on March 27th to the 29th, 2019 at the Driscoll Hotel in Austin, Texas.
The next Certified Ambulatory Surgery Center Administrator, or CASC exam, CASC exam, is scheduled for May 1st to the 31st, 2019 at testing sites throughout the United States, and the electronic application must be submitted between March 1st and 31st, that's this month, 2019. And for more information, please visit aboutcasc.org or aboutcasc.org.
ASCA 2019 will be at the Gaylord Opryland Resort and Convention Center in Nashville, Tennessee, May 15th through the 18th, 2019.
And we'll be there in force, and we'll be doing a special episode from there. The New Jersey State Association 9th Annual ASC Conference is May 28th through the 29th at the Hilton East Brunswick, 3 Tower Center Boulevard, East Brunswick, New Jersey.
The Association for Professionals in Infection Control and Epidemiology, or APIC, 46th Annual Conference is June 12th through 14th, 2019 in Philadelphia, Pennsylvania.
The Arizona Ambulatory Surgery Center Association Annual Conference is June 27th through the 28th, 2019 at the Camelback Inn and Spa in Scottsdale, Arizona. And I do want to emphasize again that if you would like your organization to be represented or to be part of the ASC Podcast with John Goehle, please contact us at info@ascpodcast.com. And we'd be glad to see if we can make time in our schedule to visit and do a special episode from there. So that's it for this episode of the ASC Podcast with John Goehle. Until next time, please do us the honor of hitting the subscribe button, and we'll see you in a couple weeks.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all the rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development, all rights reserved. We would like to thank this week's sponsors. First, Ambulatory Healthcare Strategies, one of the nation's leading regulatory compliance and financial oversight firms. For a free consultation, contact John Goehle today at 585-594-1167 or through email at info@ah-strategies.com. And Eden Group Development, which publishes ASC Regulatory Compliance Series, the ASC industry's leading books including the Survey Guide for ASCs, a guide to the CMS Conditions for Coverage and Interpretive Guidelines for Ambulatory Surgery Centers, and Ambulatory Surgery Center Governance, a guide for ambulatory surgery center owners and governing body members. These must-have books are available on Amazon and Barnes & Noble or directly from the publisher at reg-books.com. That's reg-books.com. If you're interested in advertising or sponsoring the ASC podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.